This conference will now be recorded.
An important part of the organ-based study is looking at urethral function, which has recently been recognized to be a very important part of both stress and urge incontinence. And it's actually a pretty simple thing to do and takes less than a couple of minutes once you get the core ideas in place. And so I'd like to go through and kind of show you what the theoretical understanding of these are. For many of you, I know that will be review, but I just thought I'd make sure that we went through everything for people that are not familiar. So this is the catheter that we'll use. It's a T-dot catheter, and you can see that there are two measuring sites. One is towards the tip by the green arrow, the intravesical pressure. That transducer will stay in the bladder. And then the one that's 6 centimeters away from that is the intraurethral pressure, and they're abbreviated by custom PVES and P-ura. Now, as you'll see, what's labeled as P-ura will sometimes be in the bladder, so it actually will be measuring bladder pressure, but by convention, this is the nomenclature that has been used. So just to go over the idea, here's a little diagram to help us with seeing what's going on. There's a bladder in yellow, the urethra in gray, and the catheter in blue, and I've color-coded the two transducers in the way that we had before. You'll see that PVES is in green and P-ura is in red. And then on the urodynamics display, we'll have P-ura displayed up here and then PVES displayed down below. Now in the actual testing, there will also be an abdominal pressure catheter that's placed for women in the vagina, and if men are tested, it's placed in the rectum, but I'm just showing the two critical aspects of that at this time. And you'll see that because the two transducers are placed in the bladder, the two dots on the graph are the same. They're about, let's just say 10 to 15 centimeters of water. So the basic idea is to pull the catheter down along through the urethra in order to get a profile of the pressures as it descends. So a urethral pressure profile. Now, as we pull, you'll see that the catheter starts in the upper part of the urethra, goes through the high pressure middle zone, and then eventually comes out to the outside world where it's measuring atmospheric pressure. So it's that drawing the catheter through the urethra that allows us to be able to get this profile of urethral pressure. Just to go over it again in diagrammatic form, it starts out with both transducers in the bladder, A on the diagram, goes through the peak urethral pressure at B in the diagram, and importantly, it ends up in atmospheric pressure at point C, where the external transducer is outside. It's important because it allows us to be sure that that transducer actually is measuring measuring atmospheric pressure. Now, for the definitions, there's maximum urethral closure pressure, which is the maximum urethral pressure minus the bladder pressure, and also maximum urethral pressure, which is the difference between atmospheric and the bladder. So if we look at atmospheric pressure to the bladder, that's maximum urethral pressure. And if we look at the distance between bladder pressure and maximum pressure, that's the maximum urethral closure pressure. Closure meaning the advantage of the urethra has over the bladder. Now, once you've pulled the catheter out one time and gotten one profile, we're going to do that 3 times, and so the catheter needs to be replaced back into the bladder. So as you will be able to see, there is a reverse tracing that happens, and usually by tradition, the first pull is the one that we use for data, and the second one can be quite short, as you'll see in the next tracings. But you will see that for each time that you have the peak, and then in order to replace it in the bladder, you'll have the reverse. Now here it is in a simulation with a model. It's a little bit funny in that the catheter was longer than the bladder in the model, so you'll see it kind of coming outside, but you can ignore that. And it's a little bit subtle, but you can see the two transducers there, and this is what it would look like in a patient. Pull the catheter through until you see it on the outside. Then you push it back in, and you pull it out so that it's on the outside, and then you push it back in. And then that's done a third time. So that gives us 3 maximum urethral closure pressures. This is what the tracing would look like and should look like. There should be a bladder pressure each time, and there should be an outside pressure each time. There should be the reinsertion hump, followed by the data hump that you see when there's pulling. Now, the other thing that we want to look at is how much can a woman squeeze in times of need if she feels that urge to urinate and needs to increase her intraurethral pressure to avoid leakage, what happens? And for this, we're going to position the urethral transducer in the middle of the urethra at the high pressure zone. So the idea here is that the catheter will be drawn and then left in the middle of the urethra where it can monitor at the time that an individual squeezes and then relaxes. So you can see in the tracing that the catheter would be pulled down until it's at that location, and then the woman is asked to contract 3 times. Now, usually before taking this data, it's good to rehearse the patient to make sure that they know what it is that you're trying to do. And so usually we'll do a rehearsal section when we're not gathering data, and then follow that by the time that we do collect data. It's important to make sure that the woman knows that we're interested in her maximal effort, not just a convenient effort. I usually say if you were in the Olympics and trying to get a gold medal in squeezing, now is the time. And you need to monitor about how much they're performing other things rather than urethral contraction. But usually that can be done before you take the data. So what happens then, to just see it in the model again, is you pull the catheter down until it's in the middle of the urethra. Then you ask the woman to squeeze and relax, squeeze and relax, squeeze and relax. And that gives you the tracing that we've seen over here. And then it can be pulled out, as you see, until we see the pressure go to atmospheric pressure at the end. So a few points to remember. You need an adequate bladder fill to allow the catheter movement. There needs to be a little space for that upper part of the catheter. Rehearsing the Kegels to make sure that they know what they're doing, that they're doing the right thing before taking data. You must have the P-Ura sensor all the way out each time to be able to calibrate to atmospheric pressure. And a slow, steady pull each time works. I usually kind of count a little metronome in my mind once a second, like 1, 2, 3, and think about the fact that when I'm pulling it out, I want to do that about over a 3-second interval. It's not exact, doesn't need to be exactly precise, but a slow, even pull like that is usually fine. And then putting it back in can be as quick as you'd like it to be. So I'm sure that we'll have some time to talk about questions later on, and I'll look forward to people's feedback, both about whether there are other things that would be helpful in this presentation as we go along, or whether this is satisfactory.